Hi guys, let's start with a case. This is Sam. He's a previously healthy 3-year-old male who presents to you with 3 weeks of recurrent abdominal and leg pain and decreased energy. He's scheduled to have his tonsils removed and get some lab work. This is what it shows. So first let's review what is what. Here you have your CBC and your BMP, or your basic metabolic panel. This is your white count, your hemoglobin, and your platelet level. To read the BMP, go as follows. This is your sodium, potassium, chloride, bicarb, BUN, creatinine, and serum glucose. So what stands out? Well, his white count is certainly elevated, and it ended up that this was his first presentation of T-cell ALL, which leads us to what we're going to talk about today, which is tumor lysis syndrome. So tumor lysis syndrome, or TLS, is defined as a diverse group of pathologies in which abnormal metabolism and life cycle lead to profound derangement of a host's metabolism. And the 3 organ systems that we worry about the most with TLS are the cardiac system, neurosystem, and renal system. So basically, TLS is developing from the rapid destruction of malignant cells, which leads to an efflux of their cellular materials out into the bloodstream, and then you can have this end organ damage. And a lot of things can contribute to the breakdown of these cells, but some of the things we worry about would be drugs, whether that's chemotherapy, immunotherapy, radiation, steroids, basically when any patient is beginning therapy for their malignancy. Dehydration, which is why the hallmark of treatment for these patients is really going to be IV hydration. Children, especially boys, are more at risk of developing TLS. And the blood disorders like leukemia and lymphoma have a higher risk because there's just more rapid turnover of cells. Okay, so there's basically 4 metabolic derangements that we worry about with TLS. You're going to see high potassium, phosphate, and uric acid, and low calcium. First, let's start with potassium, which is in high amounts in normal cells and even higher amounts in malignant cells. So when these cells are destroyed, they're released out into the bloodstream. We start to get most concerned when levels are greater than 6.5 milliequivalents per liter. And the 2 places we worry about potassium the most are in the heart and skeletal muscle. So in both places, high potassium levels are affecting muscle function. In the heart, you worry about the development of tachyarrhythmias, which can eventually lead to death. And there are many pathognomonic changes that you can see on an EKG in these patients. Do you guys remember the most common? That's right, peak T waves. So anytime you see potassium this high, your first step should be to get an EKG. In skeletal muscle, high potassium is mostly manifested as weakness and general dysfunction. Next, let's talk about high phosphorus. And most of the issue with phosphorus comes from its close relationship with calcium. So it's a natural binder. So when you have high levels of phosphorus, that's going to bind up a lot of your free calcium, leading to an overall decrease in calcium because there's less free amount floating around. And we start to get most concerned when levels of phos are greater than 7 milliequivalents per liter. And the sites that we worry about the most are again at the heart and at the kidneys. That kind of looks like a kidney. So at the heart, we worry about deposition of the calcium phosphate directly into cardiac tissue, which can lead to arrhythmias and death if untreated. And in the kidneys, these same crystals can form in the renal tubules, leading to ischemia and endothelial injury, and eventually renal failure. Lastly, let's talk about high levels of uric acid, which are actually the most common feature of TLS. And both this and phosphorus typically happen sooner in the time course than high levels of potassium. So we're talking in the first 48 hours of starting treatment or so. And you start to get most concerned when levels are above 8 milliequivalents per liter. And the main site of concern here are the kidneys, where you can have direct deposition of the uric acid crystals in the glomeruli, which leads to endothelial dysfunction, and if left uncorrected, can lead to local ischemia and eventually kidney failure. Well, now that we know what TLS is and the risk it poses for patients, how do we go about preventing it? Well, for TLS, the best treatment really is both early and aggressive. And its form really comes in preventing it in the first place. The mainstay of treatment is hydration, as well as addressing the individual electrolyte disturbances. So let's discuss that a little more. So in terms of hydration, all patients are typically started on 2 times maintenance IV fluids, keeping in mind that you do not want potassium in those fluids. And then you're going to address your specific electrolyte abnormalities. So the biggest one that we can directly treat is the high uric acid. And you have 2 options for that. You can either prevent the formation of uric acid or help it to be better excreted from the body. So you probably remember a little bit of the uric acid pathway. And this involves purines, which are the building blocks of DNA, and thus very abundant in malignant and rapidly dividing cells, being broken down and eventually getting to the liver, where xanthine oxidase, an enzyme, breaks it down into uric acid, which is what we're worried about depositing. So if we were to affect this process to block xanthine oxidase, we would therefore decrease the amount of uric acid being formed. And that's accomplished with something called allopurinol, which is a medication that can be given both IV and PO, keeping in mind that it has multiple drug interactions, so always talking to your pharmacist when you're prescribing medications for patients on a variety of medications. But let's say our levels are already high, so uric acid greater than 8 or so. So we really want to get rid of uric acid from the body in that case. And in those situations, we can actually encourage the breakdown of uric acid into another compound called an allantoin. And this is done with a medication called respiricase, which works to activate the enzyme urate oxidase and thus promote uric acid excretion from the body. So as a general rule, most patients are started on allopurinol early in their course to prevent formation of uric acid, and then respiricase can be used as a corrective measure if uric acid levels are quite elevated. Now, what about potassium? Well, like we talked about before, hyperkalemia is the most life-threatening complication of tumor lysis syndrome. And if you're seeing those EKG changes that we talked about, so peak T waves, etc., and you're worried about the development of tachyarrhythmias, the first thing you should do is administer something called calcium gluconate. Calcium gluconate is a cardiac membrane stabilizer. So when these membranes are becoming more excitable by all this excess potassium floating around, this will work to stabilize those membranes and hopefully prevent the development of tachyarrhythmias. So calcium gluconate is really a stabilizing measure, but it's not going to do a whole lot to actually help to decrease the amount of potassium in the body. The variety of things that we can do to shift potassium back into cells. Keeping in mind that overall the body may be sodium depleted, right? Because we're just releasing all this potassium out into the bloodstream. So things we can do would be to give IV insulin, along with dextrose, of course, because these patients don't have high sugar levels and you don't want to make them hypoglycemic. Other things could be a beta blocker, such as propranolol. Albuterol could also be used, such as in a nebulizer, but that's really not that beneficial. The mainstay of treatment for this is really going to be insulin and dextrose. And then there's slower measures that you could think about, such as diuretics, keeping in mind you would not want to use a potassium-sparing one like spironolactone, but instead favor a loop diuretic, such as Lysis, or even oral binders, such as K-exalate, which can help bind potassium in foods and excrete them through the GI tract. So, like I said, you have your calcium gluconate to stabilize your cardiac membranes in an emergency situation. Your insulin and dextrose would be the mainstay of treatment in the short term to lower your potassium levels. And then diuretics and oral binders are more long-term options to try to decrease the total amount of potassium in the body. Okay, so the last electrolyte that we have to address is high amounts of phosphorus. And really the mainstay of treatment of this is addressing phosphorus absorption in the GI tract and trying to increase the amount of phosphorus that's excreted just through our body's normal mechanisms. So we'll often do Tums, which would help bind some of that phos in the gut, as well as something called sevelamer, which is an oral binder like K-exalate was for potassium. We typically start patients on this when their phosphorus levels are greater than 6, and they take it when they eat foods. So the sevelamer works to bind that phosphorus that's in the food and just excrete it from the body naturally. So in summary, the main principles of treatment of tumor lysis, which again is really comprised of prevention of it, is working to shift potassium back into cells. If you're seeing those high levels of potassium, looking at an EKG, and then of course if you're seeing those worrying tracings, starting calcium gluconate right at the get-go, working to reduce phos and uric acid with the different medications that we talked about. And overall, our big fear is progression to renal failure. So all these measures, plus aggressive fluid hydration, are working to prevent that. So there you guys have it, a review of tumor lysis syndrome, or TLS, which is the increased turnover of cells leading to an efflux of different electrolytes into the bloodstream, namely potassium, uric acid, and phosphorus. If untreated, this can lead to end organ damage and even death. Addressing each of the electrolyte abnormalities is key, as well as aggressive IV hydration. Great work, everyone!